Medtronic technologies impacted more than 72 million people in the last year, equating to 2 people every second. Harnessing the power of technology to take healthcare further, each technology has unique benefits designed to serve patients. The goal of this program is to get closer to the patient and delve into the challenges and impact of each technology in practice. This is the Medtronic MedEd Learning Experience. No monitoring system should be used as the sole basis for diagnosis or therapy, and they are intended as an adjunct in patient assessment. Reliance on a single monitoring system alone for patient management is not recommended. The contents and conclusions of the following programs are solely those of the speakers unless otherwise cited. The speakers are responsible for all content and any necessary permissions. The speakers receive funding from Covidian LP, a Medtronic company, for this speaking engagement. Medtronic's medical education programs are offered to provide attendees education on FDA-cleared indications and use of our products when applicable. For this segment of the series, a discussion on patient safety and procedural sedation. Have we noticed a change in safety or quality based on the time of day the case is being done? To help answer this question, our gastroenterologist, Dr. Ashish Chawla, and CRNA, Brian Berry.
Dr. Chawla, the trend in gastroenterology is high volume endoscopy and colonoscopy. GI does a lot of cases in a day. Have you or your colleagues noted a difference in the safety or quality based on the time of day for the procedure and when it's completed?
Yeah, I think we have. And, I would say there's high volume procedures in pretty much any procedural sedation. There's high volume cardiac caths going on, there's high volume IR guided procedures, but certainly in colonoscopies and endoscopies, we have noticed a relative difference. And the difference is at the end of the day, we get tired. And I think that's not a bad thing to say. I think that's just human. So if we look at a couple of studies done from the Cleveland Clinic, they show some pretty striking results. They were taken with interventional endoscopists and tertiary care endoscopists who work in hospitals, and they looked at high volume endoscopy success rates and quality rates and compared them if the patient's case was done in the morning versus the afternoon. And again, they're kind of sobering results. When you look at patients that were done in the morning, the success of the procedure, the ability to get to the end of the colon, called the cecum, was higher in the morning than, of course, in the afternoon. And the incompletion rate, vice versa, was higher, of course, in the afternoon. If we look at quality, so quality in a colonoscopy is dependent upon how often we find precancerous polyps. We call these things adenomas, okay? How often we find them and remove them. So the higher the adenoma or polyp detection rate, the better or higher quality the colonoscopy, most of our studies suggest. And again, a difference. So in the morning, we find polyps at a greater frequency that are adenomas than in the afternoon. And again, going back to the study, these are tertiary care interventional endoscopists out of Cleveland Clinic when we're comparing this data. And another sobering point behind all this is what we found is complications actually increase later on in the day. And I think one of the things that come to align with this is that we all get tired. Mistakes happen.
Thanks for that thorough response, Dr. Chawla. I thought that was very educational and will definitely provide some insight. My next question is, the easy answer, obviously, to improve quality and safety seems to be, hey, let's just do less cases. Obviously, that's not reality. Given the backlog of the cases that were not done during the 3 years of COVID, the pandemic, new requirements now that everyone should get a colonoscopy at the age of 45. Aren't you impressed that I knew that? And the push for insurance companies to do more non-operating room anesthesia cases. How can we leverage technology to help with this fatigue that you're talking about to improve patient safety in non-operating room sedation cases?
I think, it'd be foolish for me just to say it's a one-sided thing. I definitely think reducing alarm fatigue, giving our technicians, our nurses, our CRNAs more breaks. I think reducing distractions all play a role. But the low-hanging fruit here is we have to leverage technology that exists to help improve patient quality and safety. And one of the things is using capnography to rapidly identify hypoxia and respiratory depression before it happens. So capnography actually measures the end-tidal CO2. And by measuring the end-tidal CO2 and looking at the rate in the capnography as well as the diagram in the capnography or the waveform, we're able to identify patients that have either occurring obstruction, partial obstruction, complete obstruction, or apnea long before these events actually occur. So, for example, capnography is actually able to detect mild hypoxemia during procedural sedation about a minute and a half before, and severe hypoxemia 3 minutes, up to 3 minutes before standard monitoring. So we need to leverage our technology to kind of find out before these events occur. So I say this to a lot of my colleagues. I say, think of capnography a little bit like blindside mirrors, okay? Those rear blindside mirrors that we use, these side viewing mirrors, okay? I've driven a car for 35 years. I've done it successfully and I've changed lanes. But after a hard day of endoscopy, coming home in my commute, I rely on these things all the time. I'm fatigued. I make mistakes. I acknowledge this. And having something that can kind of remind me it's safe to turn or not to turn is critical. And I think we should liken capnography to that. It's an instrument that can help us detect problems before they happen.
Thanks for your insight, Dr. Chawla. My next question for you is, how does capnography prevent hypoxemia or severe hypoxemia?
Yeah, great question. So anytime we put oxygen, and we do this in all procedural sedation, we basically use our pulse oximeter to tell us how the patient's breathing. Problem with that? If the patient stops breathing or has reduced breathing because of obstruction, we don't notice the drop in their oxygen saturation until 1 to 3 minutes later. Capnography basically reduces that. By actually detecting the end-tidal CO2, it detects apnea, altered breathing, partial obstruction, and complete obstruction before the O2 sat monitor declines. During this time, we can do maneuvers like a chin lift, a jaw thrust. We can, instead of giving more sedation to an agitated patient, give less sedation. We can turn up the oxygen. So does this actually work in real time? Absolutely. So if you look at data from gastroenterology in monitoring patients with just pulse oximetry alone versus pulse oximetry with capnography, we notice that there's a marked reduction in the events of hypoxemia, severe hypoxemia, and actual prevention of respiratory depression, as outlined by these two graphs.
Outstanding. Thank you, Dr. Chawla. Last question. So what do our societies suggest about the use of capnography?
I think because of the non-operating room standards that have come out, we follow the American Society of Anesthesia guidelines, which suggest that every patient undergoing mild, moderate sedation outside should utilize capnography in their procedural sedation units.
Thank you very much.
Please tune in next week for a new segment from this series wherever you find your podcast. This is the Medtronic MedEd Learning Experience. Thank you for listening.